Hello everyone, this is Randy Clough from MCOL, and I would like to welcome you to our webinar event today, the Medicaid Managed Care Proposal Rule, Digesting the Details and Implications. Our speakers today are Bob Atlas, President Strategic Advisor for Epstein, Becker, Green, and Helaine Fingold, Senior Counsel, also with Epstein, Becker, Green. Before we begin, we do have a few housekeeping items to cover. If for any reason you experience technical difficulties with the web portion of today's presentation, please print off the PDF version of the presentation that was included with your dial-in instructions. The link is healthwebsummit.com/Medicaid072215.pdf. Our speakers will be taking questions today using the live chat feature. So now and at any time throughout today's webinar, you are welcome to submit your questions. As always, if you require any other assistance, please contact the Healthcare Web Summit office at 209-577-4888. We are now ready for our speakers to begin.
All right, thank you, Randy. This is Bob. I'll be joined by Helaine Fingold, as Randy introduced, and we're going to tag team this. We'll be back and forth throughout the presentation. I imagine you'll be able to tell when I'm talking and when Helaine is talking. So we have a lot of material, as you probably know if you've looked at the actual proposed rule. It's very long. If you count the preamble and all the explanations, somewhere north of 500 pages long, and so we're trying to digest that in short order. As Randy said, if you have questions, type them in the chat box. We can see that, and we'll see if we can answer them while when you ask them, but we may hold them to the end if it's going to disturb the flow. So without any further ado, there's oops, I'm sorry, I'm clicking on the wrong thing. Hopefully there's our lovely visages on your screen. And just a little clarification, Randy said I was with Epstein, Becker, Green. I'm with EBG Advisors, which is the consulting arm of Epstein, Becker, Green, the law firm. So moving right along here, here's our table of contents. There's a lot of subject matter to go through here, so I'm not going to read you this agenda. We're just going to dive right in. A little bit about managed care to get things started. So as many of you probably know, Medicaid, by head count anyway, is the largest payer in the U.S., now covering about 71.5 million Americans. About 9 million of those, I think, were added due to Medicaid expansion and other effects of the Affordable Care Act. Medicaid estimated spend total for all states and federal government combined in 2015 is about $540 billion, which makes it a bit smaller than Medicare, which with 55 million people has fewer lives, but of course on a per capita basis they're more costly. And of course, as you probably know, about 10 million of the Medicaid beneficiaries are dually eligible for Medicare and Medicaid. There are 39 states that contract with comprehensive managed care organizations for Medicaid, and when you count number of beneficiaries, about half or more than half of all Medicaid beneficiaries, about 55–60% by some counts, are getting care through managed care arrangements of some kind. So the last time CMS issued a comprehensive Medicaid managed care rule was in 2002, and they've certainly given states a lot of direction since then, but they made a decision that enough has occurred that they want to put out a comprehensive rule for Medicaid managed care that will cover all of the updates that they've been giving more or less on a guidance basis. I'll make a note here that Medicaid managed care and this rule, for the most part, also governs the Children's Health Insurance Program, or CHIP. There's a few small areas where they may divert, but we're going to ignore that for now, and you should assume that everything we're talking about applies to both Medicaid and CHIP. So this map, courtesy of Kaiser Family Foundation, shows the state's utilization of managed care. The dark blue states are the ones that just use MCOs. There are some states that use a mix of MCOs and primary care case management. And then there's a number of states that just use, in the light blue, that just use a primary care case management only. You'll note it says may include ACO. So I'll just note that while a lot of states are fiddling around in some fashion with ACOs in Medicaid, there's no actual formal definition of ACO in the Medicaid statute. And for the most part, CMS governs ACO arrangements under the rules that apply to PCCM programs. And then there's a small handful of states, Alaska, Wyoming, and Connecticut, I think, are the only three that are not doing any kind of comprehensive Medicaid managed care. So I'm going to, one more slide for me. So why did CMS do this? Well, they say that they want to modernize managed care and Medicaid and CHIP to reflect changes in the way managed care is delivered across the U.S. And perhaps more importantly, they want to amend or modify the rules to align better with Medicare Advantage and with the qualified health plans sold through the Affordable Care Act marketplaces. And so, you now have a situation where CMS, for the first time in history, is really in some way regulating all aspects of the health insurance market. And it became evident to them that they would like to harmonize the way that they execute that regulation across these several domains. So that's somewhat what's behind these regulations. So now I'll turn it over to Helaine to talk about the kinds of entities involved.
Hi, good afternoon. And as Bob was saying, the CMS has indicated that they want to kind of harmonize across the Medicare Advantage and the exchanges and bring the Medicaid rules into alignment. I think some of that has to do with some of the people on the edges, maybe at the upper reaches of the Medicaid eligibility, that might be moving back and forth into the exchange products depending on where their income levels are. And it's going to be a lot more kind of smoother transitioning for people where there's comparability between sort of the Medicaid plans and the exchange plans, and probably will improve the perception and operations for the plans that might be in one market but hadn't gone into the other market. They might benefit from the comparability across. It will help them and maybe encourage them to be in both markets. So specifically, what kind of entities are affected by these rules? It does apply to all of the Medicaid, the different types of Medicaid managed care entities, which would include the more comprehensive managed care organizations and the more limited PIPs and PAPs, prepaid inpatient health plan and prepaid ambulatory health plans, as well as the managed long-term services and supports programs, the long-term care programs. There's a new term, a new entity that CMS proposes to identify here, and that would be the PCCM, Primary Care Case Management Entity. And these have developed over the number of years, entities that are doing enhanced PCCM services. They may be getting a more robust capitation. They're not just doing a case management. They might do some other more extensive things, and that CMS wants to make sure that they're meeting the same types of requirements where that's appropriate as the other managed care entities. And as Bob mentioned, the ACOs, these rules do not apply to ACOs or primary care medical homes under the terms of the regulation. So what are the network adequacy requirements? Again, in an effort to be more consistent, more in alignment with the types of rules that are under the exchanges and under Medicare Advantage, these Medicaid managed care rules would propose to have states set time and distance standards. Those of you who've been in the Medicare Advantage world know that MA moved to a time and distance process a number of years ago, and it's still working out some of the issues there, but has running relatively smoothly now. These would be applicable to specific provider types. You see those listed. Some types they specify between adult and pediatric, and asked for comments among the areas where CMS specifically requests comments on whether there are additional provider types for which the rules should specify between adult and pediatric, so there wouldn't be a single standard. There are exceptions allowed, again, similar to Medicare Advantage, where there are exceptions where you don't meet the defined standards, and this would allow for exceptions, but only if the state is going to monitor those exceptions. Timeliness is categorized under this as routine, urgent, or emergency. So in assessing whether the access is adequate, you would be using those categories. And then there's a range of other factors that the states are told they would need to consider, including, what's the expected enrollment for Medicaid, what's been the historic utilization of services, what's the population look like, are there particular ailments or particular characteristics that would influence their needs. Also things like reasonable accommodations. Are providers able to have physically to address accommodations for people with disabilities, but also in terms of communications for people for whom English is not their first language, and also just in terms of disability issues. So there's a wide range of issues that the state is supposed to consider, and in addition to also looking back at Medicare Advantage and how those rules apply and what the standards are, and what the state is doing in the commercial market, so and whether that's applicable and how that would affect it. Another push in these regs, which is comparable to what is happening in the Medicare Advantage and also on the exchange side, is transparency requirements. The state would, and you'll hear this in a number of these areas, but particularly on network adequacy, the states would have to publish the network adequacy standards, so there is transparency. So, so people with that are involved, stakeholders, have to understand to be able to understand what the state is doing. The MMC entities would have to certify network adequacy at least yearly, and when there's a significant change to operations that would affect capacity and services. So it may be an expansion of area, it may be the addition of a new service that they're including. They have to, where there is a significant change, they would have to come back and assert to their adequacy. So the managed long-term services and supports have specific network adequacy standards. They're largely the same as for the regular medical services, but there's some things that are specific to the needs in the long-term care space. For example, if the provider or the enrollee have to travel to get to the services, that has to be built in, and also just to ensure that the health and welfare of the enrollees are being considered to make sure that the community integration is being achieved, which is really the goal. So CMS did ask for comments again, and these certainly, we've encouraged our clients to make sure to comment at least where CMS has asked, and certainly for any other areas where they have concerns. But CMS all throughout this rule is balancing the need to ensure kind of predictability across the markets, but also to allow states the flexibility, and they're definitely looking for input into where that's going to fall on either side, whether they should give the states more flexibility in defining the access measures rather than having CMS put them out there, and that's varied across the Medicare Advantage and exchange markets, looking at whether the time and distance as they have proposed, but whether in fact they should go a different way and go to like provider to enrollee ratios or some other basis. And then again, as I said, the pediatric providers, whether there should be additional ones with specific time distance standards, or whether like behavioral health should be included. So they're definitely asking for input. Bob's going to take it back and jump into the medical loss ratio.
Sure, thanks. I'll just mention, since Helaine was talking about CMS seeking comment, many of you probably have actually looked at the full regulation. In case you don't recall, there's a deadline, I think it's 5 days from today, for submission of comments on the draft rule. So there is still time if you do want to submit comments. So let me talk a little bit about the rules on medical loss ratio. What's interesting here is that you'll notice on this slide about CMS's authority, I'll get back to the definition in a second, but CMS is, in the middle two bullets here, is giving a justification for why they're proposing a minimum medical loss ratio. The reason they're giving this justification is there is actually no provision in statute that authorizes CMS to impose a minimum medical loss ratio in Medicaid. It does exist, as it shows on the bottom of the slide, in the Affordable Care Act for the commercial markets, both individual and small group, as well as large group, as well as in Medicare plans, the 80 and 85%. So you're probably already aware that the health plan industry has pushed back on this, saying that CMS does not have the statutory basis to make this establish this minimum ratio. So we'll see what happens there. They define the medical loss ratio as, incurred claims plus quality improvement expenditures divided by premium revenue minus certain taxes and fees. The term incurred claims, of course, can include monies paid out in the form of subcapitations from an MCO or PIP or PAP to a provider group. It's basically healthcare spending. And so they're establishing this minimum requirement of 85%. They're saying states may choose higher minimums. I might just note that some states haven't waited for this regulation. While the information I'm about to share may not be completely up to date, there's about a dozen states that already had a minimum medical loss ratio. Those ratios range from a low of 80% in states like Illinois and New Jersey and Washington, to a couple of states that actually go above 90%, specifically Hawaii and Virginia, that are in the kind of 91 to 93% range. And several other states fell right in at about 85%. So some states have already done this, and now it will become the law of the land if CMS gets its way here at a minimum of 85%. There's a few differences between the commercial and the Medicaid MLRs. There's somewhat technical differences. This one is calculating the MLR over a 12-month period instead of 3 years, as the case under the ACA for other markets. And there's some, the provision is that states collect a remittance if the MLR is less than 85%, whereas in the commercial marketplace, the health plans owe the money to the subscriber population. There's some exclusions and inclusions. One thing I'll note there, a little sub-bullet, the MLR can actually, can be reduced in effect by 0.5% for acceptable fraud and abuse activities being conducted by the managed care entity. So I referenced in the ratio the health quality improvement activities, and these are things that are, by CMS definition, likely to improve health quality, increase the likelihood of desired health outcomes occurring, and that are grounded in evidence-based medicine. Obviously, there's a lot of subjectivity there. What's interesting is this comment CMS believes this definition is broad enough to encompass things like service coordination, case management, other efforts for community integration of persons with complex needs. So that does open a window for a variety of activities that health plans might conduct to aid beneficiaries in their experience of managed care. And so you might expect a lot of focus on the definition of those things. I'll just offer up a little bit of an opinion here. I don't think that the 85% minimum is a huge challenge in Medicaid for plans to meet, because most Medicaid managed care is done in a mandatory enrollment way, so the marketing expenditures that plans incur are lower than they are proportionally in a Medicare or commercial environment, and so that substantial percentage that goes toward marketing and sales is reduced. And that's not to say there aren't other administrative tasks that a Medicaid managed care plan has to perform, but I don't think, my own opinion is that a lot of plans will not suffer tremendously with that 85% minimum. There's a provision that the rates that are set be actuarially sound. This is not really a new provision. It's just new, clearer articulation of what the definitions of actuarial soundness are. I'm not going to read you everything that's on here, but I think these things that say, these points here under where it says incorporate principles of actuarial soundness. Rates should be sufficient for anticipated service utilization and compensate plans for reasonable non-benefit costs. This is probably a good protection for plans. As many of you know, in some states, the states have, when they've suffered budget woes, they have turned to the Medicaid managed care spend and cut the capitation rates, and that will be more challenging for them to do if they can't demonstrate that the sufficiency principle is being met. And so I think that in those states there's some benefit to the plans. There's also this point about the state needing to certify or have an actuary certify each individual rate, and they don't. This regulation does not allow for rate ranges. What's a little bit perplexing is the fact that right around the same time that CMS issued this regulation, they also issued a guidance document. It's labeled a draft, dated June 5th, to states specifically around rate setting. And in that rate setting guide, they did say that ranges were acceptable, but as long as the actuary certified that the ranges, everything between the top and the bottom of the range was legitimate, it was acceptable. So some commentators have noted that there are some inconsistencies between this draft rule and that policy guidance, and in fact the National Association of Medicaid Directors has already written a letter to CMS pointing out some of the inconsistencies. So we would expect CMS to respond constructively and smooth out those inconsistencies. A couple other things around actuarially sound rates. A lot of states have started putting in incentive arrangements, so they're not simply paying a flat capitation, but they're putting in some quality goals that enable sharing of upside or downside around the capitation number. And so there's some guidance here on what's a legitimate incentive arrangement, and it has to be tied to quality goals. It can't be more than 5% of the capitation rate, and they have to confirm actuarial soundness. And then the lower part of the slide shows the process that CMS will follow and the sanctions that might be applied if CMS believes that states have not met the actuarial soundness. Obviously, the notion of punishing by withholding federal financial participation or matching funds would be rather significant, so we would presume states will adhere. Now back to Helaine to pick it up on quality of care standards.
Thanks, Bob. I'm going to just jump back and make two brief points. One on the quality of care and the medical loss ratio, like as Bob was discussing. From a legal perspective, we would recommend where you're expending resources towards quality of care and you want that to be considered as part of your MLR calculation, it's best to write a note to the file to document your intent sort of upfront when you're planning, when you're making those expenditures, rather than waiting until a possible audit some years down the road, where then you're going to say, well, yes, that was part of our quality effort, but it's more difficult to establish that sort of in hindsight. So if you're doing that, definitely try and keep that documented. I'd also just briefly mention a recent Supreme Court case where there were individual providers were trying to challenge a state's rate setting, and that was not adequate reimbursement rates. And the Supreme Court found the case was called the Exceptional Child Center, and that the Supreme Court found there was no private right of action, which is essentially when a private entity is trying to enforce the law that they're saying that the federal government hasn't enforced. That there was no private right of action for the providers to force the states to change their reimbursement. We think that's probably going to result in a similar prohibition, that there wouldn't be an ability under these rules for the managed care plans to challenge this. Once CMS has said that the rate setting is adequate, there wouldn't be an ability for the managed care entities to challenge the state's rate setting. So just wanted to reference that. On quality of care, again, very similar themes as we move through. Efforts to align with the other types of systems, ensure stakeholder engagement, increase transparency. The impact hits at the upfront when the plans are being assessed by the state. It's in the operational portion where they're required to monitor themselves and do performance improvement projects. And then there's the external, the quality rating system, so that there's more transparency, so stakeholders have a better understanding and can better select based on quality issues. And then there's external review systems. So CMS is very clear that this entire program, the entire implementation of the quality standards, would be through notice and comment, to develop standardized performance measures and the topics for PIPs, performance improvement projects, that it's about a 3 to 5 year trajectory based on that mechanism. So the quality rating system itself, which again, it was similar probably to the star ratings around Medicare Advantage, and that the exchanges will be creating based on clinical quality management, the member experiences, and plan efficiency, affordability, and management. Again, what it turns a robust public process, including notice and comment, which again is generally the Federal Register issuances, but CMS has certainly gathered comments through other mechanisms. 3 to 5 years. CMS is proposing to define the standardized measures, but would also allow some flexibility for the states to define their own measures, and they would want the methodology to be reassessed to ensure that changes are going to be dealt with on a 2 to 3 year basis. States that already have a QRS, a quality rating system, could keep what they've got or modify that, again, with CMS approval. And transparency, the ratings have to be online to help beneficiaries. External quality review from outside the plans would include looking at network adequacy, which would be a different approach than really just looking at assessment of availability. You really have to see how they're meeting the availability, how the plans are actually providing access, making sure the information maintained is accurate, which we've heard again a lot in the press in both the exchange market and the Medicare market, where plans have errors in their provider directories, and that's been problematic, and several plans have been sanctioned for such things. And also just making sure to monitor, they'll make sure that there's monitoring with the wait times, with providers to determine wait times. States could look to the results of a Medicare review or private accreditation surveys on some of these EQR requirements, though that would not apply to network adequacy. I believe they wouldn't be able to look to a standardized accreditation assessment of network adequacy. And again, as with the network adequacy rules, generally there has to be something that's specific to the long-term services and supports. I think I might have, okay. We're going to appeals and grievances. So the appeals and grievances tightens up some of the requirements for beneficiaries protection. So tightens up the requirements on the plans to better protect beneficiaries. Plans could only have a single level of internal appeals before a beneficiary could then request a state fair hearing. The timing is shortened, so it's going from 30 days to 30 days from 45, so that's shrinking by 15. And then expedited appeals are now 72 hours as opposed to 3 working days, which obviously could extend over a weekend and then thereby be longer. There's a clarification of documentation that beneficiaries could get, and would be a requirement that the benefits that are being challenged have to be continued while the appeal is pending. So, Bob, I think you're next on the enrollment protections.
You bet. So one thing that you may all be wondering is, how do these rules operate when so many states have waivers, either 1915B program waivers, or as many states are doing 1115 demonstration waivers? And to the best of our knowledge, they still want most of these, if not all of these provisions to occur, to apply, even when waiver programs, including 1115, are operating. In particular, it's been long-standing CMS policy and practice to put the beneficiary first in their minds, and so these beneficiary enrollment protections can be assumed to be sort of non-waiverable in many respects. I'm not saying that's absolute, because in an 1115 situation, in theory, anything is possible. But if you've dealt with CMS on this already, you know that they are pretty rigid about things around beneficiary enrollment protection. So, and a lot of the rules, not just in this area, but across everything we're discussing, these are things that CMS has been telling states administratively for quite some time in many respects, but they're deciding that they're going to just put it all down in one place and let it be known to everybody. But there's not a lot of really shocking news here for those who have been in this game for a while. I suppose that in a way it may reduce the work of consultants like myself, because a lot of our clients have had many questions from around how CMS will govern various things, and it's been a little bit more of a mystery. Now it'll be a little bit less of a mystery. So these beneficiary enrollment protections, their goal is to try to get some consistency across the different state enrollment processes to protect beneficiary choice. It applies to MCOs, all the different PCCM and PCCM entities. Some of the things that we talked about, by the way, like the actuarial soundness and the MLRs, those by definition don't apply to PCCM entities because there's not a prepaid health benefit going on there. PCCM usually works but not always in collaboration with a fee-for-service model. So states still retain their flexibility to use a mandatory or voluntary enrollment processes, but the rules now say that CMS has to give beneficiaries informational notices constructed in a certain way, and to allow a 14-day choice period accompanied by interim fee-for-service coverage. So even a state that's doing absolute total managed care still has to allow for any beneficiary to have a 2-week fee-for-service period, which means that a state has to keep its fee-for-service claims paying engine operational, even though that might only be handling a very small fraction of the total spend. I also want to make, Helaine and I have been covering for each other a little bit or going back over each other's subject matter a little bit. There's a thing that Helaine may not have emphasized. There's some remarks in the rule that says that, with regard to quality, CMS wants the fee-for-service side of Medicaid to also have many of the same quality provisions. So they're not, which is a huge difference from what might be the tradition. So just something to note on that side. There's an expectation of continued services to beneficiaries and coordination and continuity of care. When people are transitioning from delivery systems or from fee-for-service to managed care, there's a requirement for receipt of services for a period of time after transition. So, somebody is leaving fee-for-service and going to a provider and going to a new provider in managed care. There has to be continuity protection there, and there's expectations around coordination of care with community and social support agencies, not just healthcare providers, and a strong requirement for health risk assessment to be performed within 90 days and to be shared with other providers. So again, for those of you who've been in the space a long time, a lot of these don't sound particularly new. This is really codifying things that CMS has been telling states for quite some time in most cases. Here's a little bit of additional information about the specifics of the choice periods. So if they use voluntary enrollment but not passive enrollment being where people are put into a managed care arrangement but they have the ability to opt out, there's still a requirement for a 14-day choice period and an opt-out. It's only after the 14-day period can they be assigned into a default plan. Likewise, if there's a voluntary enrollment period with passive enrollment, then they have this same thing on the 14 days, and then they can do auto-enrollment. They have to give confirmation notice of the plan selection and notify of the right to disenroll within 90 days. And this note about the clarification that the 90-day only applies on the initial enrollment period. Of course, a lot of states do this auto-assignment to Medicaid managed care plans. Typically, when people are offered the choice, more than half, maybe even 3/4, don't make a choice, so the state auto-assigns them, and CMS, again, has long required states to have certain criteria, and they're now, again, codifying this. Most notably is this notion of preserving the provider-beneficiary relationships and keeping traditional Medicaid providers in the mix. If that's not possible, then to do a equitable distribution among the available plans and can't arbitrarily exclude any plans. Some states, of course, will will tilt the playing field a little bit in favor of plans that, let's say, score highest in a competitive bid scenario, and this does not seem to prohibit that. And then other kinds of criteria that sort of make common sense, based on locations, previous plan assignments, access for the disabled, and so forth. And there's, again, some specific remarks about comments that CMS is looking for. So moving along, I just want to let me pick it up to the utilization management. Is Helaine sent me a note saying she might have skipped the slide. If we did that, I guess, Helaine, if you want to go back onto the quality, if you feel you missed something.
Yeah. Let me, I don't want to get people dizzy with if I skip back. Let me see. Let me just back up 1 minute. Oh, I think somehow these got out of order.
There's a little bit out of order, that's all.
Okay, so yes, we talked about the quality of care standards, that the transparency and alignment, the quality rating system. I think that's what happened, is the appeals and grievances we talked about, and the quality of care, the external quality. So we did get it all in there. I think we're a little bit out of order. So let's keep going. We are on utilization management, which is largely looking at limiting controls on limiting the ability to use utilization management on clinical services, that to make sure that they take into account, that the plans would take into account a person's ongoing chronic conditions, need for long-term services and support, so that they may have a little bit different approach than they might use with somebody without those types of conditions. That the states would have to monitor the authorization activities and how the plans are implementing, prohibit any kind of that's interfering with family planning freedom of choice, and it also clarifies that medical necessity would include criteria related to the EPSDT, early periodic screening for the under 21, as well as treatment of mental and physical issues and conditions. This similar to the appeals, the expedited authorizations now would have to be made within 72 hours as opposed to 3 working days. So I'm going to move on to we can't be back at, okay, manage long-term service and support. Somehow I think those quality slides got intermingled there. So the managed long-term services and supports, again, are being treated. There's clarification that there are new requirements on the MLTSS that are provided through the various MCO and managed care mechanisms, including enrollment and benefits complaints, an ability for individuals, enrollees, to file for complaints, that there's additional education requirements. Some of these, I think, similar to some of the other areas, were in guidance and are now being added to the regulations, including these key principles that are identified and that will apply now, again, under regulation. The proposed rules would clarify state monitoring standards, so the states would have to make sure they're monitoring and overseeing the plans in a range of areas. Again, this reads very much like some of the requirements on the Medicare Advantage side, that make sure the plans are appropriately administering and managing the product and the delivery, looking towards marketing, program integrity, managing provider networks. So you can see the range of areas. It will be interesting to see how the states are handling this, given the there's shortfalls among many of the states, and difficulty. And granted, I think there's an intent and a hope to be able to monitor, but we'll see how they manage to monitor this range of areas. But the state would have to submit their annual assessment, the program assessment, to CMS, and again, for transparency purposes, have to post that publicly. States would also be required to conduct readiness reviews. That's another thing that is part of the Medicare Advantage and Part D market, where there are readiness reviews conducted for new entrants. So here, prior to the start of a new program, they would be required to do a readiness review, as well as new contractors entering, in addition to adding a new benefit or population or expansion of a geographic area. So that is a significant expansion of what readiness reviews have been doing, at least on the Medicare side. The readiness review would look at a minimum, the plan's operations and administration, service delivery, which, that's going to be interesting to look at it prior to when services are being delivered. So you're really just looking at how the plan is structured and what are their processes in place for doing this, but you're not actually obviously going to be able to look at it in action until it's happening. It would look at financial management and systems management, again, the processes, and, are you structured in a way to be able to address all the issues? But for a plan that's just starting, you're really just looking at their preparations. So there's also a strengthening on the information standards. Again, the theme of transparency, make sure that information is disseminated, to strengthen dissemination rules, align with Medicare Advantage and commercial markets, to address technology advances. Again, 2002 was quite a long time ago in the world of technology. So there's want to move towards the future to make things available in a variety of mechanisms technologically. They're asking for posting of provider directories in a machine-readable format. Again, on the exchange side, similar, and Medicare, where they're trying to encourage third parties to come up with tools that might facilitate access for beneficiaries and others to see the information, maybe on a handheld device or some other mechanism. That this would also strengthen the requirements for making materials available in prevalent languages in an area. Again, very similar to the other markets where there's taglines required that would say to somebody in their language that you can access this information in a variety of languages. So on the Medicare side, there is information that CMS puts out about what languages are considered prevalent in various areas, and I would anticipate that they would do something similar on the Medicaid side, or perhaps use that same information. So the vital documents, there are certain documents that wouldn't apply to necessarily every piece of information that comes out of the managed care entity, but there are some that are considered vital: provider directories, member handbooks, anything addressing appeals and grievances, and anything that really is critical to obtaining services. So, I think the default is probably more than less, but it isn't everything that's there. So Bob's going to come back and give us our wrap-up on our key takeaways, and then we can open up for questions.
Thanks, Helaine. So, well, while I'm finishing up here, think about typing in your questions. We will have a few minutes to take questions before we have to wrap up at the top of the hour. So a few things to think about. What does this all mean from a big picture standpoint? Again, repeating a little bit of what we said at the beginning, why does CMS want to do this? Well, they want to harmonize across Medicaid, managed care, Medicare Advantage, and qualified health plans, which, all told are covering, perhaps 100 million people soon enough. They're looking for administrative simplification so that plans and others who are involved don't have to do different things for every one of these programs. They want to see the same kinds of beneficiary protections across all these programs. and they want to see continuity for beneficiaries as they transit between the different domains. So there are people in, who are in the Medicaid space who might end up in a Medicare Advantage plan, or as their income goes up, they might end up in a qualified health plan. So they want the greatest consistency in these areas, so the beneficiaries will have a fairly common experience as they go from one place to the next. And thinking about the impact on different stakeholders here, starting with providers, our opinion is that this is generally positive for providers for a number of reasons. First of all, there's this floor on the medical spend as a result of the minimum medical loss ratio and the actuarial soundness requirement. And so that ought to protect providers against sort of a race to the bottom in terms of fees and perhaps what they might think of as excessive utilization constraints. At the same time, there's a greater value being placed both administratively and perhaps financially on healthcare quality, and so that ought to be something that would work to the benefit of providers. And the same thing about consistency across all three domains ought to help providers, because they, in terms of fulfilling reporting requirements, you might expect the quality reporting or other kinds of reporting to be more consistent across all three areas, and that might reduce administrative burden and simplify people's lives. From the standpoint of health plans, we're saying it's neutral to positive. It's going to vary from one state to the next. The actuarial soundness, as I commented earlier, probably promotes a kind of a minimum adequacy of capitation rates, and therefore that should help health plans in some respect. The state-to-state consistency probably lessens the burden on plans that are operating in multiple states, because there won't be such wide variation in the rules from one state to the next. And then the impact on states themselves. There are obviously major stakeholders here. And, one can only speculate, but in those states that perhaps have the most developed Medicaid managed care, they may be the ones who experience the greatest burden, because they've already locked in a number of procedures and systems and so forth, and these rules may mandate that they go back and unwind some of that. That's not necessarily true the case, though, because, as I said, a lot of the guidance that CMS has issued in the past is essentially now just being codified. So hopefully it won't be a big burden on those states. And for states that haven't gotten very far along in their evolution of Medicaid managed care, this now gives them presumably clean and clear guidance on how to go about running these programs. I suppose it also creates more mobility for state employees, for state staffers who want to pick up and move from one state to another. They should know what they're getting into better when they move from one place to another. So I see a number of questions have come in, and some of them are fairly lengthy, worded at some length. Let's see. Okay, the first one: how does this affect, if at all, Puerto Rico? Helaine, do you know the answer to that?
I do not off the top of my head. I think we can certainly look into that pretty quickly and get back to you, get back to the person who asked.
Okay. The next question is there a regulation on how much incentive a plan can give a potential beneficiary to enroll? I know we didn't touch on that. CMS is very, very fussy, even before the issuance of these rules, about inducements to enroll. I I imagine that, I don't know chapter and verse, Helaine, maybe you do, in terms of whether they've codified that. You want to pick that up?
Well, I would be concerned that the incentives also could run into afoul of some of the OIG issues, the fraud and abuse rules. So I'm not aware of a specific limitation, but that is probably something that would take that depending on what type of incentive, and certainly, generally I think the enrollment incentives are not allowed, but we can again get some more detail on that and get back to her.
So, all right. I would say, the incentives have to be, they cannot be overt inducements to enroll. The only kinds of incentives really they have to be health-related and of nominal value. Things like, baby diapers or a car seat or something like that. CMS looks very unkindly on more salesy kinds of incentives. They don't want to see that. Here's an interesting question that's complicated. In a risk deal with both quality and spends, if a group or IPA comes in below 85% MLR and does not hit the quality incentive with total MLR less than 85%, is the plan still meeting the MLR reg in this situation? That's a little bit of a puzzle. First of all, I would say the only rule that applies to the plan is for the plan in the aggregate. So if at the end of the day the plan has put out substantial dollar, 85% or whatever the state's minimum MLR is, but it could be higher than 85 number, in aggregate, then the plan will meet the rule, and the rule does not have to be met with regard to every downstream capitated provider entity. In terms of how that's measured, I think that if a plan pays an incentive to a provider, so let's say that the initial payment was worked out to be 83%, and then they gave them a 3% quality bonus, that would be counted as 86%, and therefore it would probably meet the rule. Helaine, you want to try to take this next question? I can read it. Have you already looked at it?
Do you mean the one on the language requirements? Yep. Yes. So it's not specific to
you need to read it out. Read it.
Oh, yes.
You need to read the question.
That's right. Sorry, I'm jumping ahead. So the question is regarding the language threshold data. Is this determined by general census data, or is it dependent on individual member data per plan? So it's essentially, are you really looking at who's enrolled in your plan, or are you looking across general information? And the answer is it's general. It is related to the people in your area. So you probably at this point could look at census data, but again, CMS has on the Medicare Advantage side, and I believe on the exchange side, does identify for plans, or has identified for plans, what the levels are. So often it's either a 5% or 10% level if there are people in the area that speak a particular language as their first language, then those are generally the required languages you have to make them available in. I'm sure there will be additional guidance around how they're interpreting that, but there will likely be something put out by them, and it is just general across the area, not specific to your plan.
Okay. Next question, and I know we're just about out of time. Let's try to quickly take about a minute. Do these regs apply to MAP, MLTC, and FIDA? Gosh, I know a lot of acronyms. I know with the last two, MAP, I'm not sure what that is, if that's Medicare Advantage or what. But MLTC, yes. I mean, there's specific language in here about long-term care that's listed here. CMS and states now call that managed LTSS. And FIDA is the dual demonstration, and I think that there's probably some exceptions, but to the extent that there are Medicaid beneficiaries impacted by the duals demonstration, I think that one could assume that these rules will largely apply. Next question is, this seems like a large volume of changes that impose very little change on existing program designs and practices. Do you see anything in here that has a high likelihood of changing existing, one or more existing programs, or existing, I'm not sure what this, oh, somebody said okay, I apologize, I'm looking at two questions at once. A comment I made earlier, I don't see this changing a lot of existing programs. I think that there are some programs that are, you might call a little bit more outliers, that states have pushed the envelope, and I think this will bring them a little bit more on center. But I don't want to say that this regulation should meet with a universal shrug either. I think that there's a lot here. There's going to be a lot of new administrative burden on states to do, particularly around the monitoring and certification and the like, around actuarial certification and so forth, much more data and so forth. So I think that this is upgrading the degree of regulation, but it is not necessarily going to impose radical change. Anyway, that's all we can handle, I guess. Let Randy take it to wrap up.
Okay, thank you, Bob. We'd like to take this opportunity to thank both our speakers and session participants for joining us today. We will be sending a follow-up feedback form at the conclusion of this event and would love to receive any feedback or questions that you wish to share. If you haven't already done so, please be sure to join our LinkedIn group on the web where you can post questions, start discussions, and suggest topics for future events. This now concludes our webinar.